The primary thing that kids do is play. And so a lot of our interventions for pediatric populations is going to be playtime. But the importance of that playtime is about the position that they are in order to maximize their functional development and motor development. And so another key component of pediatric intervention is going to be positioning and handling, not only you promoting the right positioning and handling in session, but being able to educate caregivers on appropriate positioning and handling. So this lecture is going to be a pretty quick review of these things. I want you looking through the pictures in your textbook, and I've got the pages pretty well identified through here. But a big component of this portion of things is going to be the actual practice and doing the skills component. So review the pictures as we go along with this PowerPoint in preparation of practicing these skills when we come to class. We look at function related to posture. We've got several postures here we can look at. Supine and prone are the lowest postural levels in which a child can function. And so by lowest, we mean lowest developmentally, but also lowest to the ground. And functional activities that can occur in supine and prone include rolling, reaching with the upper extremities, looking, and propelling the body. In a seated position, the child is appropriately oriented to the world in that upright position, and we can encourage functional use of the upper extremities, but we have to have trunk control in order to do that. And so once trunk control is established, we can add upper extremity movement to promote greater trunk control, but we can't incorporate upper extremity motion until that trunk control has been established. In the quadruped position, we allow the patient to get in the position they need for creeping, which provides quick mobility from a modified prone position. And the quadruped position is a progression from prone. Remember, we talked about that developmental sequence in the last lecture. And so it does tend to be a simpler position to achieve for those mobility purposes, especially when you compare it to standing. Standing is the highest level of function, and it can increase bone mineral density and range of motion, and also decrease spasticity and improve hip stability. So even in patients where functional standing may not be part of their day-to-day life, we still want to promote standing postures when we can to achieve these physiological benefits. Physical therapy intervention in the pediatric population should be implemented in through the daily routine. The motor development is the most influential in the pediatric population, and so we can get the biggest gains, but time constraints tend to be a big issue because parents and caregivers are the ones having to coordinate, deliver, or participate in the pediatric interventions during the home time. And so putting things into the daily routine as much as possible so that it is not an additional demand on the parents can be a huge way to get better patient carryover as well as better patient compliance with performance of the home exercise program. Sitting is the best position. It's the optimal position for eating, bathing, playing, all kinds of ADLs. And so encouraging parents to perform daily activities with their children in a seated position as much as possible will help with that postural control and motor development. The upright position is important in developing the child's interest and engaging them socially. And if you remember us talking about that cycle of motor development being stimulated by sensory stimulation, which then stimulates motor development and stimulates sensory stimulation, that cycle has to work together, and the upright position is the best way to help stimulate the sensory system for that. When we are teaching parents to provide assistance for the activities that they are doing, we want to teach them to provide the appropriate level of assistance. It can become easier for parents to just pick up their kid and do whatever needs to be done. Okay, you're on the floor and we need to get into a standing position here, let me lift you up. But that doesn't promote the child's ability to gain control of the motion or independence with the task. And so we want to teach parents to provide the appropriate level of assistance so that they have their kids working in that range that promotes the zone of proximal development. So they're always trying to push themselves a little bit more, and we're always gaining a little bit more independence. When implementing a home program, stretching is going to be a huge part of that. And so, we want to use our positioning for developing trunk control and motor development, but stretching can place a limitation, or range of motion deficits can place a limitation on the functional gains that come from that functional positioning. And so stretching can be an important part of maintaining the appropriate postural alignment so that we can get appropriate motor development. Again, we want to remember that time demands should be considered, and the requests that we make for stretching should be realistic. These aren't going to be the same stretch prescriptions you're going to give an adult, because the patience level in a child is not the same. And so you may have shorter bouts of stretches, but longer or more reps of them to achieve the tissue compliance changes that you're looking for. We want to encourage parents to incorporate these things into bath time and diaper changes, so that way we're reducing time demands, but also we're putting kids in positions where they're already a little bit more comfortable, a little bit more relaxed, and stretching can happen. And make sure that we are providing adequate handouts, especially with the pediatric population, because parents have a lot going on and they may not be able to absorb all of the information you're giving them in a session. And when they are not the ones physically performing the things their child is, there's a harder ability to remember those things when they get home. When we're considering positioning, we want to prioritize positioning for function, right? We want to ensure that the child has access to as many of the sensory stimuli as possible that's appropriate for their age, as well as the mobility opportunities. And so when we are positioning for function, we need to consider alignment, comfort, and support being a big consideration for safety. The positioning should serve to prevent deformity and promote movement. So not only do we want to help promote appropriate postural alignment when we are positioning a child, but we want to position them in a way that they are able to move and they are not restricted. If the child can't maintain a posture when they are propped, then assistance is required to ensure safety. And so applying that appropriate level of assistance to promote independence is important while ensuring safety. And consider the functional needs for the child's level of development is important in determining the appropriate positioning. So what does the child need to be able to do at the age that they are, and what positions are going to help them achieve that best? Motor development is most often helped with working through the prone progression that we talked about in the last lecture. So we're looking at prone to prone on elbows, to prone propping, to a quadruped position, into a tall kneel, into a half kneel, into a stand position. And so we can look at all of those positions and consider the functional demands of the child and the deficits that are presenting and determine which position would they benefit from the most. When we talk about handling at home, parents should be taught the easiest ways to move the child from one position to another, both for their body mechanics and the child's body mechanics. Caregivers should be taught to allow the child to assist as much as possible, remembering that zone of proximal development. And then movement transitions are a major part of a home program. So the things that we are going to practice in lab as far as how we get a child to transition from supine to sit, or prone to sit, or sit to prone, or prone to quadruped, all of those transitions are a huge component in what we will teach parents as part of pediatric care, because those movement transitions need to be practiced the most at home in order to get the greatest independence. And if the child is only learning them 3 times a week in their therapy session, they're not going to get that carryover. And so home exercise programs for the pediatric population are going to focus a lot around movement transitions. Holding and carrying positions are also important to educate patients on. A child with increased lower extremity tone should not be picked up under the arms, because that can cause an effect in their tone where their arms then don't have the shoulder support needed and they can slide out. A child with low tone should also not be picked up under the arms. And so again, that tone not having the stability at the shoulder girdle needed when somebody lifts them up under the arms could force their arms into a fully flexed or abducted position, and then the child slips from the caregiver's hands. And so we want to pay attention to how tone affects the ability to carry a child. Patients who may not tolerate prone positioning may tolerate prone carrying better, and so we can teach carrying positions as well. I do believe it's like page 123, maybe, somewhere. I have it referenced on one of these slides later on. But the holding and carrying positions shows how to not lift the child up by an arm, or under their arms, but also what alternatives you have as far as providing support under the ischial tuberosities and to the trunk. And the handling techniques for movement, we're going to dive into a little bit more here. So wherever your hands are on the child, you have to remember that the child is not in control. You are. So if you have hands on a portion of the child's body, you are controlling the movement there. They are not in control of it, and so they are not independent with it. as long as you continue to provide support there and don't decrease your support or move it away more distally, they will not develop support. And so paying attention to your hand placement is important based on what the child needs are, so that way they're able to contribute as much as possible. The support should be moved distally as the child progresses to encourage more control. Stability can be facilitated by positioning the limbs in a weight-bearing or loaded position. We want to allow the child to do as much of the movement as possible. The effects of gravity can be reduced by using an elevated surface. So instead of having a child in supine where the effects of gravity are maximal on head and trunk flexors, we can put them on a wedge to decrease that effect of gravity and help promote strengthening in a range that they can move through. We want to carry the child in a way that forces the head and trunk muscles to be used to maintain an upright position against gravity. Again, always trying to help promote midline orientation, upright positioning, and trunk control. Do not pull against spasticity. We want to use rotational movements and positional changes to help reduce spasticity when that's present in a child. We want to be mindful of the patients with sensory sensitivities, especially when applying touch to the child in whatever intervention capacity that is. Children with low tone tire more frequently, and the supine position should be avoided. We want to put these patients in prone to promote that extensor tone on the spine and neck for head and trunk control. The ultimate goal is for the child to initiate and guide their own movements. And so most of the things that we are going to do with children are going to involve play so that we can promote that initiation of movement, but we have to have them set up in the right position and with the right tools to be able to accomplish that. So I would review intervention 5.4 on page 112. Looking at positioning and handling intervention, just kind of a reiteration here. Make sure that we allow the child to move as much as possible. We're always encouraging head control. Don't pull against spasticity. Promote weight bearing, especially for children with athetosis. Place low tone children in prone. Use care in your hand positions and decrease handling as the child gains control. Sensory deficits can be an issue in the pediatric population, and so desensitization exercises can be important, but also understanding that we can use a child's senses to help desensitize them to whatever positions we are trying to achieve. It's important to consider, a patient who has never had any experience laying in prone probably isn't going to be comfortable because of that sensory stimuli and sensation of touch. And so we may need to do some light touch desensitization to the abdominal region to get them comfortable with being able to lay on it. And then progressive weight bearing on that surface can help increase the tolerance. When we're utilizing touch, we want to pay attention to the child's perception, stimulate the arms and legs before we ever go to their face because they can't see what's touching their face, and so that can cause an adverse reaction as far as emotional, psychological response. And always try to stimulate in the direction of hair growth to decrease the irritating sensation that might be perceived by the child. When we're utilizing the vestibular system, we want to use movements to challenge head position. So having a patient in prone, swinging in a hammock can help them with the looking up and looking down so that their head has to maintain an upright position as they move through the positions on the swing. Sitting a patient on a Swiss ball and having it roll side to side can help them with the lateral head stability because they have to have a lateral neck flexion to maintain an upright head while the trunk is taken into that side position on the ball. And so utilizing the vestibular system to orient the child to upright can help promote those muscle activations. Movement stimulation often works to alert a child who is lethargic or has low tone. So utilizing, again, the vestibular system with quick motions or promoting head motion can work to wake up a child who's lethargic on you. Fast, jerky movements facilitate an increase in tone for children with low tone. So if we have a child with low tone, like in Down syndrome, we want to promote faster movements to generate that tone that we're looking for. But we want to avoid those in patients with high tone or spasticity, like CP. And in those patients, we want to use slow rhythmic movements to decrease their tone. Approximation can be used for that irradiation effect and increased muscle firing and improved proprioceptive benefits. So weight bearing through the joints is probably the best way to achieve approximation. However, there are some pictures in your textbook on how you can achieve approximation with a child in seated and in quadruped, and I believe also in supine it shows approximation through the pelvis, because if we don't have stability in the standing position, then we have to work through our developmental sequence to achieve it at a lower level. Children use vision to help explore their environment, and so visual cues or visually stimulating toys or objects can help to promote motion or movement in a therapy session and encourage child participation. And vision also contributes to head control and balance. And when we look at hearing, hearing doesn't directly affect postural control, but there is the impact of the ability to respond to sounds that can contribute to head control. And beyond that, if we have a child with a hearing deficit, we want to pay attention to what vestibular deficits might also be present, because we know that vestibular cochlear nerve travels together for vestibular input and auditory input. And so we need to ensure that there's no vestibular deficits that are going to impair the child's balance as they progress through the developmental sequence. When we're preparing for movement, we need our patient in the proper position with the proper muscle activation and proper stability. And so in looking at those things, we need to look at postural readiness. Does the patient have sufficient resting tone to maintain a position both before, during, and after a superimposed movement? If they don't have that postural readiness, then are we prepared to add movement yet? Probably not. We also want to pay attention for their postural readiness in regards to primitive reflexes. Reflexes that have not been integrated can inhibit postural readiness, like the Landau response in a prone position may promote extension of the head and neck that is improper for the child at their age, that prohibits them from being able to assume a quadruped position, and that can inhibit their ability to progress through the developmental sequence. So we need to pay attention to the integration of those reflexes and where they are inhibiting functional development. We also want to look at postural alignment, because having appropriate postural alignment is necessary for safe completion of functional activities. Proper alignment also promotes efficient movement and righting reactions so that we can maintain balance. And it's important to pay attention to how children can use excessive rotation of a limb to lock the joint instead of using muscle activation for stability, and making sure that we're not allowing that rotary locking motion and promoting the muscle firing that we need to see. When we're utilizing our manual contacts, we need to know that they're used to guide movement or reinforce a posture, and the shoulders and hips are most commonly used in the pediatric population, but we want to utilize manual contacts in the way that provides the most appropriate assistance. We want to guide them, but not do it for them. And so pay attention to your manual contacts and reduce your amount of pressure, as well as move more distal from the trunk as the patient progresses. And again, needing the muscle firing, we talked about how rotation can reduce tone. Slow rhythmic movement of the trunk and extremities is often helpful in decreasing muscle stiffness, but you have to begin at proximal joints to get the best effectiveness, and so that can help get the proper muscle tone needed for movement. We are going to very quickly run through these interventions through the rest of the chapter and the positioning movement transitions, and then we're going to practice them in class. So I again would remind you to review the PhysioU videos that can help support what we're about to discuss as far as interventions for positioning and movement transitions, but also review the pictures in your textbook that I have listed with each one of them so that it makes sense, because you'll be utilizing those things plus my assistance to practice the positioning and handling with each other and with the dolls in class. So interventions to foster head and trunk control. If we're looking at head control on page 122, prone positioning is obviously going to help foster extensor neck strength, and supine positioning is going to foster flexor neck strength. And so placing somebody prone over a bolster can help with facilitating greater range of motion up through neck extension. It can also help with desensitization of the positioning, and it can help with tone as well and combating that Landau response. For supine, we can lay them on a wedge to decrease the effects of gravity. Interventions to encourage head control continuing can also include a modified pull to sit maneuver, which you can see on page 123, and we talked about that pull to sit maneuver with the head lag. And basically we would be working on reducing the head lag as we move through that maneuver. We can also place the child in upright in supported sitting and decreasing the amount of support as they establish greater and greater trunk control. And then implementing weight shifting in a supported seated position is going to add a dynamic challenge without overstraining the trunk control needed. We can practice carrying in prone, which you can see on page 124, depending on the child's size, can have a couple of different approaches. But remember that children who don't tolerate laying in prone may tolerate being carried in prone more, and so that will get the extensor muscle activation that we need without having the sensory overstimulation that's received laying in prone. And then prone in a hammock, you can see on page 115, we talked about the vestibular impacts of that, but also, again, the extensor strength, and it helps to decrease the sensory overload that patients who can't tolerate prone can sometimes feel. Interventions for trunk control. So trunk control is really going to start with sitting, and we basically want to progress the trunk to more and more challenging levels of sitting. And then once we have sitting and we can add sitting with reaching, we can progress on to standing, which is again going to incorporate the lower extremity support with needing hip strength, knee strength, ankle strength to support an upright position. So when we look at the progression for independent sitting, we want to start our patients sitting propped forward on both arms. And then from there, we would prop them forward on only one arm. So we're reducing upper extremity support. Then we move that one arm that's forward to the side. So we've reduced our upper extremity support, and now we've decreased our base of support. So instead of it being out in front of us, that support is to the side. Then we remove that lateral support so that they're sitting with no hand support. And then we progress to side sitting, because side sitting requires trunk rotation, and so it requires greater trunk control than upright sitting. So side sitting propped on one arm would precede side sitting with no hand support. And we can also utilize bolsters to work from that one arm support to no support as we work to that side sitting with no support final position for trunk control here. Movement transitions that encourage trunk rotation and trunk control. So the first focus should be dynamic control and ensuring they can weight shift within a position before transitions. So we want to get stability in that posture and ability to maintain that posture with weight shifting and incorporating slight dynamic movements with upper extremity movement before we work towards transitions, because that's how we can ensure the proper stability for controlled mobility moving into the skill level of motor function. So examples of these that you guys are going to be practicing through, I've listed all of the pages in your textbook, but we're going to practice rolling from supine to prone using the lower extremity. You can see that on page 126. We're going to practice having a baby come from sit to supine and coming from sit to prone, page 110 and 109 respectively. We'll practice sit from side lying, which really is just a progression of what they have on page 110, because that transition has the child go from supine to side lying to sit. And so a lot of these transitions you're going to see overlap and carry over and see how they kind of build on each other, and that's one of them. Sitting to prone you can find on page 111. Prone to 4-point, page 128. 4-point to side sitting does not have a specific picture in there, but I do want you guys to work on practicing that together. And again, we will do these in lab together. Prone to sitting is on page 109, and supine to sitting is on page 110. There are pictures and instructions for these, so I would familiarize yourself with them for appropriate practice come class time. Continuing with the movement transitions that encourage trunk rotation and trunk control, we also have 4-point to kneeling on page 128, which I believe is just a progression of the prone to kneeling. So your textbook takes the sequence from prone to kneeling to, prone to quadruped to kneeling, and it has it all in one box there. Kneeling to side sitting, again, doesn't have a picture or image in your book, but I do believe there's a video on Physio U, and we will practice that in class. Kneeling to half kneeling, you can see on page 129, and if you recall from the motor development lecture, we talked about how kneeling to half kneeling to standing is a common progression for getting to upright, and it's probably the most efficient progression. There's a picture of coming to stand on page 130 that shows babies coming to stand from the squat position, which is not uncommon for a way for them to learn. And so we want to know that we can achieve both, but as we are trying to progress our patient through the developmental sequence, so if we're working with a young child and not a toddler or an infant, then we're going to try to progress them through that kneeling to half kneeling to stand. Adaptive equipment for positioning and mobility should be used to support the best available postural alignment depending on the child's diagnosis, facilitate functional mobility, provide mobility, and encourage exploration of their environment so that they can continue to facilitate learning and motor development, increase opportunities for social and educational interactions, improve participation in the classroom and home environment, and improve physiologic functions and increase comfort. So we tend to use adaptive equipment for pediatric populations more readily than we do for older populations because of the fact that we need to maximize mobility, and pediatric populations tend to have congenital deficits, meaning that that is something that they are born with. It is not something that they have to learn how to do, but that they just do not have the ability without an adaptation. And so it's our responsibility to train them using the appropriate equipment. When we need to utilize equipment for positioning, we look at, again, developmental sequence and where they fall on that, and selecting the most appropriate posture to promote positioning, and then what devices we need within that posture. Supine and prone postures typically are going to use wedges and bolsters and are used to encourage head control. Our sitting postures are going to vary depending on where the child is at in their level of trunk control. Side sitting requires rotation and is the most difficult to move in and out of, and so it is important to remember that when we are doing our seated progressions. Long sitting is going to have some stability due to the base of support provided by the lower extremities, but if the lower extremities are in an adducted position in a true long sitting, then it's a less stable position for the child. If they're abducted in like a V-sit, then it tends to be a more stable position, but the level of trunk control will determine their ability to maintain that position. Ring sitting is going to be where the feet come together and the legs form a ring to help provide a more stable base of support for a seated posture. Remember, we want to avoid W sitting because of what it does to the hips, and it does not require trunk control, so we're not actually facilitating any motor activation there. Adaptive sitting should allow the child as much independence as possible while maintaining safety. So promoting the proper position, promoting the proper alignment, giving them as much movement independence as possible, but keeping them as safe as possible. The majority of the time, the main goal of functional positioning is to achieve a standing position. And that's because there are a lot of benefits to standing. There's the psychological benefits of increased peer interactions and just social interactions in general from a standing position versus a seated position. And they've done studies of that with patients with spinal cord injuries who go around in a wheelchair versus having a standing wheelchair that allows them to be on more eye level with their social environment and the psychological implications of that. And so if we can understand that in an adult population for spinal cord injuries, we can understand how that would also affect children. And so the psychological benefit can play a huge factor in why we want to promote standing for a child. But beyond psychologicals, we've got physiological benefits as well. Standing aids in digestion. It promotes the growth of long bones. It increases bone density. It also decreases spasticity, which isn't listed on here, but remember that weight bearing decreases spasticity. It encourages an alerting behavior to help combat any lethargy, and it allows for upper extremity usage for play and self-care to promote the highest level of independence for the child. So to promote standing activities in patients who cannot achieve standing on their own, we'll use things like standers where the knees and hips will be blocked to an extended position to maintain a stance, and then provided there's adequate trunk control, we can have the trunk freely moving, or there can be a chest support to provide trunk control as well. And then rollators are going to be your pediatric walkers that allow a little bit more mobility than your standard rolling walkers. They have more of the pivot wheels like we see with the rollator that's in the closet in the lab, in order to provide that exploration that children need. So before you come to class, remember that you need to watch all of the Physio U videos under that link. There should be 2 sections, and then each section has multiple videos. Make sure you review the Chapter 5 interventions for practicing in class, especially the ones that I gave specific page numbers for in this video, and review Table 5.3 for treatment planning purposes so that you can have some ideas for determining the best interventions based on child needs and positioning tolerance.